We are live, Judy.
Okay. Good morning. My name is Judy Birdsell. I'm one of the founders of Imagine Citizens, Collaborating for Health. Digital health has been one of the priorities that we identified several years ago, and I have to say the pandemic has absolutely confirmed our judgment that this would be a critical topic for us as citizens going forward, and something we must embrace in the years ahead. So how has the public reacted to the pandemic? I'm going to reflect very briefly on my perceptions of that, and then talk about what some of the implications of this pandemic might be for us, our behavior as citizens, and of course at some point we are almost all patients at some one point or another. So how do we react? First and foremost, I think fear. Personally, that was me for sure. I was the in-home caregiver for a 4-year-old grandson when my son and daughter-in-law were back and forth to the hospital to see their newborn, who was in intensive care. And those first 2 or 3 days, I ran all over the house. I wiped down all the high-touch surfaces every 2 hours, even though there hadn't been anyone in the door since early morning. And it was kind of like, where is the virus? How could it be coming in? Where do I have to clean? It was just fear. But quickly then, we moved to compliance, if you like. We listened very carefully in the early days to the advice from the public health experts, and we did our best. We took to heart, we're in this together, and we did our part. Along the way, it became clear that not everyone felt that way. There were those who were disbelievers. They denied that it was real or that it was an issue. Or there were some who also said, you know, it's my right to go anywhere without wearing a mask. No one can tell me this, et cetera, that group. Lately, though, I think there's been a change. Influenced by lack of clarity in the messages, sometimes even contradictory messages, and lately by the behavior of politicians over the Christmas holidays. So I think I've noticed a change in the people I interact with, and I don't think it's all a bad thing, but there's now a much higher lack of trust in what we're hearing from people who exhort us to do A, B, or C. So some of the things that I think have positive aspects, in my opinion, a couple of examples. A middle-aged couple isolated in their own home for 2 weeks so that they could go then and bring aging parents into their home for a visit. Another colleague, a retired school teacher who hadn't seen any of their children or grandchildren all over the holidays, after listening to what was happening over the holidays, decided to bring her 5 grandchildren into their home while they were asked to homeschool for yet another week. She brought them in and tutored them and assisted them in their online learning. These are not people who are anti-science or anti-government. They're people who are really trying to find some semblance of a quality of life and are considering aspects and evidence other than infection risk. For example, teenage grandchildren sitting in basement bedrooms who are really suffering emotionally from the isolation. These actions, to me, reflect citizens who are actively engaging in thinking through and reasoning, using the information they've been given, but making their own informed decisions. Informed not only by official messages, also from evidence coming at them from many directions. Media, social media, observation of family behaviors, listening to family and friends, etc. So that's how we've kind of reacted, in my view. So what about digital health? What's the connection? When I ask people who aren't involved, I say, what's digital health mean to you? They kind of go, I don't know. It's 2 words, really. To me, it has 3 meanings, and I'm going to share what those perspectives are. The first one is our personal health information. There's only 2 aspects that provide the foundation to reflect my own health journey. Me, I'm the person who is present at every interaction with the health system. And second, my complete personal health information, including my ECG tracings that I can take from the watch on my wrist. So the statement of principles that we recently released declared kind of what we think is important. And the first principle is perhaps the most important. We're entitled to full access to all of my personal health information in a useful and usable format. So it has to be a tool kind of in my toolkit, if you like. The second aspect of digital health is care when you don't actually have to be there. You don't have to be together with the care provider. Perhaps the largest influence on our behavior during the pandemic has been the introduction of virtual visits, telephone or video. These were virtually unknown in this province prior to the pandemic, but one which has many benefits for both parties, quite aside from reducing the risk of infection. Each member of this dyad, each holding a phone in an environment in which they're comfortable and familiar, they bring their own unique evidence and experience, be that medical, scientific, or job-related, family-related, hobby-related, life-related. Most importantly, perhaps, both members of this dyad now have access to a huge range of information sources outside either of their immediate context, be that monitoring devices, ECGs, wearables, data, health charities, self-help groups, online forums. There's a never-ending repository of evidence and information. I believe that this new world, where both parties are in familiar, comfortable surroundings, has the ability to provide more equitable access to information and tools, but also will go a long way to kind of providing a level playing field, and perhaps more correctly, addressing the power imbalances that are often present in interactions between patients and health professionals. A true partnership always will be built on a foundation of trust. And I don't want to suggest that digital tools will ever completely replace this. They won't. But there'll be a huge adjunct to both parties, I think. The third place where digital health will have a big influence is in our communities. I think it's become abundantly clear during this pandemic that the solutions to reducing infections and the full impact of the coronavirus will be found in our homes, in our workplaces, and in our communities, not in hospitals. Sadly, hospitals will always be the place where the people who get very ill will need to be cared for. But community-level information and tools are another critical digital resource that, in this province at any rate, it's taken much longer to kind of embrace and learn and act on that evidence. We know that in some communities where there's a large number of people living in a single household, and many of those people need to go out to work so they can't isolate, there are higher rates of infection. It took us a lot longer to act on that information than it did to address the virtual care, virtual visit aspect. Perhaps understandably, we focused our attention on those aspects of the traditional healthcare system, and not on our homes and workplaces. I included a picture of a bus in this collage to provide another example of an issue that I think will be solved by people in communities and digital tools. Our bus service in this province has recently gone out of business to connect rural communities. So elderly people, people who don't drive or have a car, are now having trouble getting to the city to see medical specialists. So I'm confident that with community leadership and some innovative, hopefully digital tools, we'll be able to solve this. So how should the experience this past year, and how will it affect our behavior in the future? I have three things, I think. First, we need to move our focus upstream into our homes and into our communities. Second, we need to work and create expectations to keep those innovations and things that really have been positive during the pandemic. And third and last but not least, I think we all need to own our health. We need to own our health, our personal health, our family health, and our community health. And we'll all be the better if we can embrace digital tools with our own responsibility. Now, Shweta, over to you.
Thank you so much. Thank you for the work you do, Judy, and sharing it. Thank you to the Inventors team for convening this really important topic that is timely and is going to continue to resonate as we move through this COVID timeline, from emergence to resilience to post-COVID, and what the new normal is going to look like. Often when we think about new technologies that are introduced to deal with the different challenges that arise, whether we're talking about impacts related to climate change, health issues, infectious disease outbreaks, we often are missing the component of behavioral science. How is it that we understand people's perceptions around the risks that they are facing, here specifically related to their health? And then what does that mean in terms of understanding behavioral outcomes? That is a critical component to ensure that people adopt the different solutions that are presented to them. And so Judy was able to give a real case study as to how that's happening. And I'm going to zoom out a little bit and talk a little bit more broadly about behavioral science. That's the title of our session, to give you all an idea that this is a vantage point from which we really need to approach some of these challenges and adoptions of technologies to be able to address these challenges. So let's start with, what is behavioral science? It's a cross-disciplinary science that understands the cause of individual, group, and organizational behavior across different levels. So behavioral science encompasses social sciences. It brings together insights and methods from a variety of disciplines, which includes behavioral economics, organizational behavior, neuroscience, cognitive psychology. And under the umbrella of behavioral science, these disciplines, which individually cannot actually provide a complete picture of human behavior, but under this umbrella, we now get a comprehensive understanding as to why humans behave the way they do, and how these behaviors are linked to perceptions, as opposed to the actual base rate statistics and data of various risks. So once I convince you that it's our perceptions that drive our behaviors, it becomes easier to explain some of the behaviors we've witnessed throughout COVID-19 and to be able to predict behavioral outcomes. So let's start with how we're wired. Since the dawn of our species, our brains have been designed to react in certain ways to the risks around us. We overreact to those that are novel or unfamiliar or have the potential for catastrophic consequences. And that's fine. It's worked out for us pretty well for the most part. Because, for example, our ancestors would see a poisonous snake and immediately jumpstart the response system to react and to hopefully run away. There were cues in the environment that their brains would rapidly scan and process to assess the risk. For example, what's the color of the snake? What's its position? What's its stance? Are there any other animals around? Most of this processing and subsequent decision-making was subliminal and automated. That's a relief, right? Because if our ancestors needed the time to really think through the decision-making and what they needed to do, the snake might have won and maybe we wouldn't be here today. But we've changed a lot. The risk landscape has changed a lot since then. And the risks we face are starkly different from those of our ancestors. But the way our brains are wired haven't changed that much. So even though we have more time today to process information about the risks around us, we still tend to make snap judgments. And none of us are immune to this, even those of us who study it. I'd love to share this slide so you can see. You can see here at this graph, and it compares perceptions versus the reality of different risks. And I'm happy to share these after. You can see across GMOs, heart disease, where we over and underestimate different risks. And we tend to overestimate risks that aren't that serious, like related to COVID-19, getting vaccinated. And we underestimate serious risks, like the potential for a disease outbreak to ground our lives to a screeching halt. It's because we're programmed to be overconfident. We think it's not going to happen to us. We're programmed to ignore serious but slow-moving or seemingly invisible risks, again, like a microorganism such as COVID-19, completely taking over our lives. COVID has been a prime example of all of this. When there isn't a disease outbreak, there is significant complacency and an underreaction to the very real risk of disease outbreak. Once COVID emerged, we witnessed overreaction. If you all recall, shelves were being cleared of toilet paper, canned goods, hand sanitizer. And now we are in the life cycle of the disease where we're experiencing collective behavioral fatigue, this very real cognitive adaptation to accommodate a new risk. And we've seen this with emerging diseases in the past that have stopped being unfamiliar to us, like measles, like swine flu, like HIV. Think about when you stopped being worried or caring about these diseases. Did it take a vaccine to do that? The risk, in this case, COVID-19, takes its place now among our risk landscape. It's scarier than the flu, sure, but it's not worth the same level of caution as earlier in its emergence timeline. So we'll now revert back to somewhat adjusted, but still a status quo of behavior that was pre-COVID. And there are definitely permanent changes, though. I'm not saying there aren't. So falling back to default settings won't be exactly what it was before COVID. Like distributive working environments, more or less, are going to probably persist, if not become permanent, or digitized health systems that aren't necessarily congruent, again, with pre-COVID status quo. So there's some new unique challenges to be faced with the new landscape that we're going to be coming into post-COVID. My biggest fear in all of this is we go back to being complacent, despite the frequency and probability of infectious disease outbreaks actually increasing. And again, this is how our brain wiring dictates our perceptions of risk. We're influenced by triggers such as whether or not we can see the risk, to whether or not we trust, and Judy's touched on this, who is communicating to us about it. And robust foundings from sociology describe how we even allow our political identities to influence our perception of risk. For example, those who identify as conservatives are more likely to perceive lower risk of both COVID-19 and wearing masks. They're less likely to wear a mask because of it. So I'm going to share with you a graph which shows, I'm going to share this graph which shows all of the different factors. And this is just a sampling of the factors that influence our perceptions of risk. These are well-established triggers in the field of risk perception. And they include, you can see on the list, how familiar a risk is, how voluntary exposure to the risk is, how sensational a risk is. And these and so many more shown here really factor into our perceptions and ultimately into our behavioral outcomes. The fears that fuel our perceptions of risk and even the solutions to those risks, like mask wearing, vaccinations, the digitization of health needs to be understood, and it needs to be handled compassionately. They need to be properly mapped in individuals so we can understand who, which demographics, and it varies from person to person and across communities. Who is perceiving what risk? Are people more scared of COVID or the vaccine? And how far off from the reality of the risk are they? How do we communicate effectively to close the perception and reality gap for ultimately making better decisions around healthcare decisions that are entrenched now in the data, in the facts, and ultimately adopting positive behaviors around new and necessary technologies like digital health systems? That's ultimately our goal here. We want people to have better patient outcomes. The science and tech community is highlighting digital health systems for a reason. Given the reality of what we've experienced with COVID and what's to come, we need to adapt our health infrastructure. The challenge is getting public support for these technologies and their inherent challenges, many that Judy also outlined beautifully. If behavioral science has taught us anything, it's that tailored communications to address the acute perceptions of different populations vary massively across communities, Canada, North America, and around the globe. So understanding these perceptions is a critical first step in seeing the successful adoption of digital health and all the potential positive patient outcomes to come from it. So we have to do the work, but the main takeaway really is trust. Trust in who and what is communicating about these risks. Where trust is broken, we need to do the hard work to repair it. It's not easy. It's in fact very tedious, but it can be done. I'm just going to go through a quick bullet points and we can get into some more of this in the Q&A. Some bullet points in remembering and rebuilding trust and improving communication is to know that people want to know the truth, even if it's worrisome. People can absorb a limited amount of information at a time. People do not understand cumulative risks. They fall prey to these innate biases that I've described that you can see on the graph. Emotions can cloud decision-making, but in predictable ways. Even the most experienced communicators cannot accurately predict how their messages will be interpreted, especially with new topics and unfamiliar audiences, like a COVID-19 impacting communities that we aren't necessarily familiar with. And therefore, testing and evaluation are critical. People also exaggerate their ability to predict people's behaviors. We think we know how people are going to react, but we get it wrong all the time. And people generally do make sensible decisions. That's what I'd like the takeaway to be. This isn't an attack on anything related to human nature, but we require relevant, accurate, timely, credible information. So with that, I will close my portion of the presentation, and let's move to some questions.
Perhaps, Shweta, while we're waiting for questions to come in the Q&A, I'll pick up on something you said. I've referred to a reduced level of trust, and I also think people are making decisions. How do we rebuild trust once it's been damaged, as it has, I think, in at least in our province, probably in our country, by recent events? We trusted greatly at the beginning of the pandemic, and I think that's reduced. How do we rebuild it? As you say, in communities too. I mean, it's we're not all one group.
That's exactly right. And it really is so much harder to rebuild trust. So you don't really want to lose it in the first place. It's a nice notion, but we've seen across history, across different global risks that have emerged across various sectors, from energy to transportation, that if there is perceived greediness or scandal or conflict of interest, then trust very quickly dissipates. So in the case of trusting those who are communicating the risk of COVID, we need to make sure what we got wrong in the United States, for example, was initially saying that wearing masks was not necessary, and then doing a 180 and saying everybody had to wear a mask. What we're poor at doing is communicating the state of the science. And that is something that experts need to get better in. And that's something the audience needs to be better educated in saying that it's not that people are confused or lying or have some malintention behind expressing information, but rather science is we're ever learning and we're ever getting new information. And so we're communicating the state of science and evidence that we have in that particular moment. There's a chance it can do a 180, and that's okay. So those who are charged with communicating, our public health experts in the case of COVID, need to communicate that better and say very clearly that the new evidence has come in, which has resulted in a change of protocol and a change of policy. And at the same time, audiences need to be better educated, and we need to improve science literacy. That will go a long way in improving trust. And also we need to better communicate. We need to make sure that those who are communicating to particular individuals and groups, it's coming from people that are trusted. We know that we get information from our networks through word of mouth more than anywhere else. So ultimately, identifying that person of influence in a community, in a particular community, will go a long way in ensuring that the message reaches those ears and is interpreted as intended. So I will leave it there. And I have a question for you, Judy. We do have some questions coming in, which I will, while you're answering this one, I can check in and see if we can answer a few from the audience. But I'd love to ask you, as we think about incorporating in these digital tools, and support all the achievements we've made in health, how do we ensure that we don't actually exacerbate the systematic biases that are inherent in the system now, like racial inequities, like Indigenous communities having worse health outcomes, like ageism even, for example? I would love your thoughts on that.
How we address specific communities with specific attributes is a challenge, of course. I think fundamentally, though, and I'm thinking specifically of perhaps the Indigenous question now, I think, but it applies, I think it's important to actually talk about it now as we head into the next phase of digital health, and don't pretend that we don't have huge inequities in our society. Let's not put it aside and say, well, let's get these great digital tools figured out first, and then we'll figure out how they might help specific communities who over decades and decades continue to be under supported, if you like. So let's talk about it now and not put it aside and think in the next round of innovation, we'll sort it out. And I think we need to, I mean, our approach as a citizen-led group is always to talk directly with the people that we're trying to work with. Don't speak for them for sure. Point to the issue, but don't speak for them. And don't pretend, I mean, I'm speaking very personally here, just because we don't know about something, let's not pretend that it doesn't exist. Let's learn and be humble about it. So I think that's kind of a personal message. I know I'm guilty of that in the past. If I don't have knowledge, I assume all is well. Well, I think we need to be humble and assume and admit that all is not well.
I love that, Judy. Thank you. Thank you for your thoughts on that. We have a lot of great questions coming in. If you'd like to scroll through and see which ones you'd like to answer, I'm going to pick 2 out, and I apologize in advance because the time has gone really quickly and we won't be able to get through all your questions, but I'm very easy to find, not to speak for Judy, but please do reach out and we can follow up on anything that we haven't answered yet. So the 2 that I can take on with the interest of time limits is, okay, naturalness, somebody asked. An example of that would be what is considered natural disasters historically. So something like hurricanes or wildfires. These were for a long time not seen with the high level of perceived risk that we see now, because they were considered acts of God or something that was natural. So as compared to something that is man-made, like a technology like genetically modified organisms, there were high perceived risks associated with any sort of human-made technology compared to something that is perceived to be more natural. That's changing because we're seeing increased frequency and probability of these natural events occurring, which is clearly linked to man-made actions around generally just emitting more energy into the atmosphere, more emissions into the atmosphere. And so that is playing a role in increasing the frequency and probability of what used to be considered more natural events. So that perception is changing. But for a long time, that is why we perceived less risks with things that we considered natural. And another question I'd like to address is the role of transparency. Transparency is something I actually have done some research on related to improving trust. And there is a role for it to play, but it is not a magic bullet. In fact, we found the research we did was looking at adverse events reporting here in the United States to the FDA about different reactions to drugs that have already been approved, that have made it to the market. So this is part of the regulatory post-pharmacovigilance regulatory system in the United States. And they thought increased transparency, just making every single adverse event available to the public would improve trust. It actually had a deleterious effect. So it's not a magic bullet. Too much information is overwhelming. Our brains are not designed to process it that way. We need to improve trust and expertise so that we get the information that is most relevant for us and our daily decision making. Otherwise, to make sense of that much data and numbers is just not how we're designed. And we shouldn't have to do that either. If our systems are working correctly, then people should be able to spend their time, doing what they have spent their career or studies doing, rather than having to interpret data that is not necessarily in their wheelhouse. So transparency can play a role, but it's not a magic bullet. And really it comes down to improving those relationships between the various stakeholders in healthcare. And then we'll see a higher pickup of adoption of some of the technologies we're talking about in digital health systems.
Sure does. Sadly, and thank you for that. Sadly, we're out of time and need to sign off. Clearly, we could go on and speak for hours. Thanks everyone for joining us, and I'm sure both of us would be happy to be contacted after. There was a mountain of questions that we'd love to answer. So thank you very much, Shuda, and the organizers, and all of you for joining us. Thank you.
And thank you, Judy. It was fantastic sharing the stage with you.
And thank you.